we're going to be discussing in the trenches, and perhaps Rob, if you could help me to change the slide there. So this is a real practical reality program. We're going to talk about, we're all from the Center for Connected Health. My name is Susan Lane. I'm one of the corporate managers at the center. And we're actually going to talk about how we think about and implement connected health programs. So just to let you know, we're going to focus on if you're thinking about starting a connected health program. That's the point of view we're going to take today. And there are many, many other points of view we could look at, but that's the one we're going to take today. So to get started, we have a series of panelists. I'm just going to talk to you about what we call the overarching factors, the things you really want to think about when you're starting to develop a program. The first one is that you're not in a technology program, you're not in a clinical program, you're not in a whatever kind of program you might be thinking about. You're really in the process of change management. And this is a key concept to understand. Those of you who may have read Kurt Lewin, who is the #1 writer in this area many, many years ago. There's been much more written if you look in the area of psychology, organizational development psychology. So what change management, the key concept I want to get across today, because it's a very broad topic, is that whenever you're making any kind of change, small, big, medium, there is what we call an equal and opposing force to your change. All right, and I was just talking to a couple of people prior to coming up here, and they were saying, you know, we think about something for our department, it's a tiny, tiny change, but it won't happen immediately because people resist it or they have to think about it for a long time, etc. So this is a proven theory in change management, that the minute you have any kind of change you're imposing or even involving people in, there's going to be an equal and opposing force against it. All right, that's just natural and normal. If you understand it, you'll be prepared for it and you'll plan for it. If you don't understand it, you'll be shocked, dismayed, and your program may stop right there. One of the ways we say to handle this equal and opposing force is to have an executive champion. Now, the executive champion might be a clinical person, administrative, business type, whatever it is. This is the person at the highest level in your organization who, when someone says, no, we shouldn't do this, says, oh, yes, we're going to do it. I authorize the money, I authorize the resources, I authorize the time. This is strategic to what we are doing. We're going forward with it. Many times we often suggest that you start, no matter what your plan is, you start with a pilot, and this executive champion will be the one to protect you so that you can get your pilot off the ground. Second, and equally important to the executive champion, is the administrative champion. This is the person who is the day-to-day, feet on the street, make it happen person. This person is going to worry about, do we have the right forms? Do we have the right technology? Do we have the right people in the right place at the right time? They will leave no detail alone. They are very detailed focused, and they also are the ones who signal the rest of the organization that this is what we're going to be doing, this is the team that's working on it, here's why we're doing it, and here's how we're going to do it. So really good project management skills. You also need, right from the beginning, a very clear focus of what you want to do. You need to understand right from the beginning how are you going to measure it, and we'll talk much more in detail about these, and what we call scalability. So let's say you're going to start with a small pilot. But you want to think about, if the pilot is successful, or rather, when it is successful, how are we going to scale this to the rest of the organization? So we call it scalability, or some people call it sustainability. So you don't want to be just interested in creating a little niche that works nice for the little pilot, but something that can expand and grow. And the most successful programs we have seen think about that right at the beginning, not after the pilot is successful. And then last but not least is technology. And it's very interesting. A lot of times when I talk to people, they'll say to me, gee, you have technology at the bottom of the list. It's because we believe technology should not drive the change. Technology will be a very important component of the change, and in fact will enable the change. But you really want to work with the problem at hand or the vision that you have to create a new way of doing things, in this case, in our case, in healthcare. A lot of times people come up to me and say, what's the best technology for X? And the answer really is, well, what are you trying to accomplish? And then based on that, and we certainly do work like this at the center all the time, we help people pick the best technology or technologies to enable that process. So this is the big picture, high-level view of what we're going to talk about today. And if I could have the next slide, let's see if my remote is working. There we go. We're now going to take you through what we call our decision process. We look at any program that we are setting up, either for ourselves or for others, in this way. And by the way, we set up programs both within partners and outside of partners. So we'll talk to you a bit about objectives and justification, actual program design, technology and operations, adoption and engagement, and the evaluation phase. And as you can see, we've tried to design this so that this is an iterative process. So as you move through each of these, you're actually feeding back to the original premise, your original objectives, your original program design, to tweak it and make changes as you go, and certainly to bring all that rich data back for a full evaluation of the program at the end. So I'm going to turn it over to Khinlei, who's going to talk about objectives and justification.
Good morning. I'm Khinlei Myint-U. I'm a corporate manager for program management at the center. You always start with objectives and justifications. It's not anything that's new. I think what's particularly important in connected health is, most of you know, most connected health initiatives are not directly reimbursed by the payer. But much more importantly, it tends to be something that's new for your organization and possibly very new for you. So really thinking through why you're spending the time and the resources on this particular program is a very important, critical first step. We think of objectives in kind of two phases. As Susan alluded to, the first phase is the objectives will be very different than the second phase, which is sort of the bigger objectives of what you're trying to accomplish. In the beginning, really being very clear, is this a feasibility pilot where you might be asking questions like, what is the patient receptivity to this technology? How is the patient going to react to the program elements? What is the impact on the workflow of your clinical staff? Those are the kinds of questions you might be trying to learn. Those might be the objectives of your feasibility pilot. If you're doing a research trial, you might be looking at clinical outcomes or change in healthcare utilization, or you might be really thinking about this as the first phase of really operationalizing something that's going to be much more programmatic. And so your objectives should kind of be sensitive to those things. We think it's very, very important for you to incorporate learning objectives from the very beginning. There's so much to be learned with connected health. We don't know half the answers that are out there. So being very mindful of what you're trying to learn from the very beginning is really critical. We also always recommend, and we always do this, is that even if it's not required by your leadership, to do some kind of ROI or just a cost-benefit analysis. And you might be making up assumptions in the beginning, and that's okay. But going through the exercise and doing the sensitivity analysis really helps you understand what are the drivers of cost. Where can you really get return? What are the levers that you can try to change to make your return as best as possible? And also, ultimately, it'll help you figure out what is the scope? When can I start to see efficiencies in my program? How big can it get? What kind of investment will I ultimately get if my pilot is successful? And you'll go back and kind of refine your learning objectives from that. I think the big question always is being really mindful of who is really getting the R in your ROI, because that's not always very clear. And it may not be you, and it might not even be your department, it might not even be your organization. So being very mindful of who is really getting that value from your implementation will have implications in terms of scalability, sustainability, and at the very least, it might help you figure out where you might get some funding in the future. But knowing also that as the payment or environment changes and you start to go into bundled contracts or quality contracts like what Blue Cross talked about yesterday, that value equation will change as well. In terms of program design, I mean, so you think about your objectives. You've made sure that your stakeholders have bought into it, because we've gone, if you talk about pitfalls, we've been through very many pitfalls, and the stakeholders thought we're going after clinical outcomes, and really we're going after a feasibility pilot. We were trying to understand workflow, and we're trying to evaluate workflow and receptivity to the program. So being very clear about your objectives up front. You start to design your program. And hopefully all of you know that technology is not the intervention. It's everything that goes around the technology that makes all of the difference. And that's what's going to make or break your program. So all the kinds of questions like, who are you targeting? And not only who are you targeting, how are you going to find them? Who's going to enroll them? How are you going to enroll them? What are the expectations you have of your patients? Are those reasonable expectations? That's something that you think a patient in that particular environment will be willing to do. How are you going to relay those expectations to those patients, and who's actually going to do that? If you have new clinicians in the program, if you might have health coaches that are brand new to this program, how are they going to be, what are their expectations, and how are they going to communicate and coordinate with all the other clinicians that are involved in the patient's care? If you have data that's coming in, what's happening with the data? Who's touching the data? Who's recording the data? Who's analyzing the data? Who's monitoring the data? These are all the kinds of components that you have to put in place in terms of program design. And we've had instances where people come up to us and say, I bought 20 scales, and now I'm ready to run my heart failure monitoring program. And we say, no, that's the last step. You need to think about the program design. What are you actually trying to do? What is the intervention? And we say in the very beginning, it's okay to actually be idealistic. What do you hope people will do? What do you hope will actually happen that will make your objectives successful? And those are the things that should drive your decisions around technology and operations, and that will underscore the importance of the tactics that you're going to implement that will help with adoption and engagement. So with that, I'm going to turn over to Rob, who's going to talk about technology and operations considerations.
So good morning, everyone. After a day of speaking, I'm doing my best Barry White imitation up here, so I apologize for the voice already. We came here to give you some of our real-world experiences, and to sort of put some meat behind that, I can identify, although they shall remain nameless, at least one of our major clinical users in this room, and at least one of our major partners in this room. So if anything I say up here is untrue, I encourage them, in fact, I dare them, to stand up and call me a liar. I started off with the idea of choosing a vendor, and I want to emphasize something that Khinlei said that is so critical to what we do. All of us are here because we're charting new ground in healthcare. Most of the programs that we are thinking about implementing are new. No one has done this before. At the very least, no one has done it in the way we intend to do it, in the institutions we're trying to do it, with the patients that we're trying to do it. And I'm going to ask a question. If you have too many resources, too many people, and too much money to run your programs, please raise your hand. I didn't think so. Finding the right people to help you do this is critical. And as Khinlei also said, technology is not the intervention here. But finding the right partner to help you implement the right pieces of technology is critical to success. You're going to chart new ground. You're going to use some existing technology, perhaps in a novel way. So finding someone who shares the vision and wants to work with you can make all of the difference in the world. As Khinlei said, when we build something, we may start with a pilot, but whenever possible, we try and build into our design scalability right from the very start. We want to change healthcare. We don't want to just run another pilot. As I heard someone say at an mHealth conference recently, right? We have more pilots in the Air Force, but none of them ever get off the ground. We want to change healthcare, and we want to make these things run for the long term. The question always then becomes, since we know there are just not enough people to go around, ask some of the people in this audience today who are running some of the health IT education programs, right? How many people they're trying to graduate and what kind of demand they're seeing for jobs. There just are not enough people to do this. So finding someone who can help you is absolutely critical, and making sure that you have the right people lined up in your organization to help you along the way can really make the difference between a successful program and a failure. As I said, finding the right partner is critical. But because we're charting new ground, many of those partners may have a technology or something that was never designed for healthcare that we would like to pull in. And they may have heard of HIPAA, but have no idea what it is. So part of our job when we're finding and identifying these partners may be sitting down and helping them understand not just what it means to implement or sell their product, but how to do that in a healthcare environment. Number one, I cannot tell you how many times we've had to do this. Lots of people say, sure, I'll sign your business associate agreement because they see money on the table, oftentimes not understanding what that means. We work for Partners Healthcare. We are by definition a covered entity, and so the business associate agreement is a critical step for us, and we don't want people just to sign it. We want people to honor it. So be prepared to educate your vendors and some other people on what it means to sell into healthcare. And that also goes for your in-house staff. I cannot tell you how many times we go to lawyers and say, here's what we want to do, here's some terms and conditions we think might work, let's build on this, and they look at us and go, what? So when is the patient admitted? Do we doing this in their room? Oftentimes we have to educate our own staff when it comes to new kinds of connected health initiatives, things that they may never have seen before. I did this as a benefit for my legal friends who tell me this all the time, and it's never been bad advice. Consult your lawyers early and often. I'm an operations person. I'm an operations person whose clock is not working, so I'm judging my own here. I'm an operations person, and I always keep a quote in my head. It's often attributed to General Omar Bradley from World War II. He said, amateur soldiers think about strategy, professional soldiers think about logistics. As an operations person, I often worry about how the program actually works. One of the things we've learned, a lesson that is ingrained deeply in us, and again, this is for my clinical users out there, clinical users have a relationship. What they do is build relationships between themselves and patients, and they are not liable to turn it over to just IT people unless they trust you. And they are certainly not liable to turn it over to an outside vendor. At the Center for Connected Health, we run our own help desk with our own 800 number, and that help desk is not staffed by your average help desk person. There are people who you have interacted with at this conference who are either pursuing or have advanced degrees who answer our telephone. Right? We hire master's degree candidates and master's degree level people to be our help desk. And they are people with empathy. We ask them if they are nice. We ask them if they have experience helping older people, family members, use technology. This is not your average help desk. Many vendors come to me and say, no, we can handle your tier 1 support. Probably not in healthcare. Oftentimes we take that call and then find a vendor who's willing to let us escalate what needs to be escalated. But understand, as Khinlei talked about, when you build your cost model, you're not going to be hiring your average, $7.50 an hour help desk person to do this. As Joe Caveda, our founder, likes to say, everything changes when consumers become patients. So consumer support levels just don't cut it. And more importantly, understand that you will be supporting your clinical users. If part of your intervention requires them to use your technology, you're actually supporting your clinicians. We answer questions for patients to keep our clinicians happy and using our intervention. And I think I kept that to my allotted time. So thank you very much.
I don't know if my mic is on, but as Alex is coming up, we are going to have Q&A section after this, and we wanted that to be the juiciest part of the presentation, so you can ask your questions.
I'm going to try to keep this to 5 minutes, a little shorter than Rob, apparently. I'm Ellie Pelletier. Worked on the program team at the Center for Connected Health with Khinlei, and the sections that I'm talking about aren't necessarily decision points, but more art and questions. I don't think we have actual answers to a lot of these things, but we do know where to start on some of the questions that we need to find answers to. So adoption and engagement, I see these as two separate things. Adoption is just getting it started, getting someone to use something or do something for the first time. Engagement is making it happen over the long term, and that becomes a little tricky. So you have different strategies to employ, whether you're looking at the adoption side or the engagement side of the equation. And there might be cycles through each of these as you go through, depending on your connected health intervention, but think of these two things as different. So the first thing is pretty obvious, just who are your end users? What do they need? If you've been in IT like I have for a long time, as you've heard every speaker say, it's not about the technology. It has nothing to do with the technology. It just has to work, and it almost has to work so well it needs to be invisible. What you're really looking at is what do your end users need, and they don't need problems with your technology. They need it to work, and they need it to enable what they had intended to do with it. So patients, it's a new realm for them entering into a connected health space, and what patients need, we're still figuring out. I think there have been a lot of interesting sessions about what that means and all the different permutations of what might get patients engaged. So we'll talk about that and some of the strategies that we employ there. But on the other hand, it's an elastic band back to the practice in terms of what the doctors and the nurses and the social workers, the people receiving the data or integrated into that connected health solution on the practice side. So we have, pharmacists, and we have a lot of other people, and they don't all require the same thing. They have very different needs in the practice. They have very different time constraints. They have very different reimbursement models themselves, and all of that plays into what can you expect them to do and how do you make life as easy as possible for them. On the caregiver side, that's back on the patient aspect. We're just dabbling in there, but, I think there have been a lot of interesting articles and studies done around the impact of caregivers. I'm going to care a lot more about what my family asks me to do than even probably what my doctor is going to ask me to do. Some people might be different, but if it's an effective tool to get people engaged, then we should deploy that tool as well. So, the bottom line here is everybody needs different things, and the technology has to be a tool that can be adapted to address the needs of your various end users. And it's an art, and it's not always going to be perfect, and that's where I think the hope comes in. You hope that at least you get, 80% of it okay, and then you go and iterate and make sure you can tweak the 20%. And with our programs, some that have been out there for 6 years and some for 3 or 4 years, it's just constant refinement. You can't think, oh, we've done it, it's good. There's just constant learning to be had on so many different dimensions. So it's fun, but it requires a fair bit of persistence. I'm going to check my time. I don't know what time I've got. Back to the two spheres. I've just separated it out to patients and providers. And providers is a big bucket, as I've just talked about. There's nurses, there's pharmacists, there's social workers. There's a lot of people in that bucket. But on the patient side, this is just a general example, and Kamal, who's speaking after me on the research team, probably has a better number. But just a broad brushstroke that I looked at, generally 60% of our patients in a connected health program are going to go home and do something. Well, that's pretty good, but it's not great. 40% aren't. Who are those 40%? We are in a healthcare system, so we're going after the toughest to reach patients. These are the patients where nothing else generally has worked. So whether this works or not is kind of a question to be had, but we've been fortunate enough to work with some pretty forward-thinking practices and try it on everyone and see what happens. Some of those 60% are people who nothing else worked for, and this worked. So you never quite know who that's going to be, but our job is to figure out what to do about that other 40%. And so the way that we're thinking about this now and researching in some way are the nudges. Different people need different things. If you just think about what you need to do something, whether it's reminders, an email might work for something that you're motivated around. A phone call from someone that you trust and care about might motivate you more for something that might be more difficult for you to do. An IVR, which is interactive voice response, might work for certain types of nudges, maybe medication adherence, but not for something where you're really reluctant to do. And then text, which has been surprising because it's a bit of a passive communication. It's coming over your phone. But for some of our patients, that's a very effective way to augment other things that are happening for them in the practice. So, these are all different technologies again, and we've said that technology in and of itself is not what matters. It's how you deploy that and in what circumstances you deploy that. So IVR is not going to work 100% of the time. Text is not going to work 100% of the time. But think about those nudges and how they can work in your programs. The one thing that we've really leaned on and has made a huge difference, patients like their providers. If they're sticking with you and they're trying to get better and they're at least attending their appointments, they probably like you. And the more that a provider is engaged, I think we've got some research showing that provider outreach to patients and engaging with their patients leads to engaged patients. Oh, they care about me, I'm going to care about myself, and I'm going to do something. So we have to be careful of how we try to deploy that because these are very busy people, and as we know, there's all sorts of issues in healthcare that prevent them sometimes from doing patient care. But it is a very effective tool, and maybe for those hardest to nudge, it's one that we should deploy more frequently. So we have to identify who those patients are and how to deploy that. And then family member outreach, which goes back to the caregiver model, which I won't go into too much more detail on. On the provider side, with the adoption, you first need to get to yes. So you've got your stakeholders, you've got your pilot, that's all great, but now the rubber needs to meet the road and something needs to happen. So if you can get a yes with someone who's also an influencer or someone who's just a champion, don't go for the hardest to reach people, because then you're doing too much convincing and there might be problems. Especially if you've never done it before. Go to the people who are going to be patient and go on that learning path with you and hope that they can be a good champion for you in broader circles, because if you know about the diffusion of innovation theory, to get the early majority, you need these early adopters to help convince them that it's the right thing to do. So, be tactical about who you select, but if they're very interested, almost even if they're not an influencer or you don't perceive them to be, it's probably still worth doing, because they're going to help you figure out the right way to do it. Okay, I'm going to wrap up here. So the last slide here, engagement is about maintaining adoption. So this is just reiterating what I said earlier. People doing something once doesn't mean they're going to do it long term. So how do you figure out how to make them do it long term? Part of that is figuring out the structure. If you're giving them some vague tool for some vague amount of time, they're gonna whittle out. So if you have an idea of what they're expected to do and it's very structured for them, it's going to be a lot easier for people to know what they need to do to achieve those objectives. And then use that structure to incorporate the nudges. When's the right time to reach out to patients? Big Brother, this is what we do on the back end. We just monitor program health. If we see, too much quiet, well, something's going on. What do we have to learn? What do we have to figure out? So having access to all this data is also a good way to kind of intervene and see if there are improvements that need to be made before your more formal evaluation cycle. And then incentives. I think this last point we're still working on. I'd love to hear some ideas from the audience if you've incorporated this into any of your connected health solutions. But incentives need to be there. We have some struggle structurally of how to do that within a healthcare system. We can't just pay our patients to do something. So barring that, we have to be a little bit creative about getting patients involved and providers involved. And what does that mean? So providers, we can probably use the financial leverage a little bit more, but even that's complicated. How nurses are incented or pharmacists are very different than doctors. So this is an important area that we need to explore more, so your ideas are welcome. Thank you.
Good morning. So now let's assume you've heard everything my colleagues had to say and you have a really successful program at hand. How do you really tell, right? So evaluation. Now, if you waited this far and implemented your program and then thought of evaluation, you're already too late. So I think the first critical point in just thinking about how to evaluate a program is to know that you need to think about it when you're designing the program. You need to think about what you want to evaluate, what you're really setting out to achieve, what metrics you're going to use to evaluate these various questions that you have. And then what do you really need to know about your program and about the performance to actually go back and affect the program, so that once you move from a pilot to an actual program, you have these lessons and you can titrate your program accordingly. So those are the three key points before you think about evaluation. And what I have here is I have a few questions broken into buckets so that can help you think about what questions you need to really ask. And I can give you a few examples going forward as to what metrics we've used in the past and what metrics you could think of. So the first thing you want to think of is, before even thinking about efficacy of a program, you want to think about, did you manage to reach the right patients? So for example, if you set out to reach the sickest patients who get the most readmissions, did you eventually do that? Or did you end up enrolling patients who are the youngest and the least sick because your technology required a PC to work or an Android phone to work? So just small questions like that. And hopefully you would have thought of this early enough, but evaluation is a good point where you can actually evaluate the demographics and the other characteristics of patients more closely, so that you know, okay, I need to tweak this point so that I can get the right kind of patients inside. And then conversely, what are the program designs that restricted who you could reach? And the reach could also be defined as providers. So were there some providers who were just not adopting what you wanted to give them? And there could be various reasons for that. Here's where the main part comes. Did your program work? You can think of whether a program worked or not based on health outcomes that you've defined. So, if it's diabetes, are you looking at A1C? Are you looking at number of glucose readings, glucose trends, or health utilization? So are you looking at readmissions? Are you looking at office visits, right? And then what kind of metrics do you want to define for that? The next thing that you want to think about is practice efficiency. So, if your program set out to reduce the amount of time that a practice is spending per patient, but ended up spending more time on the phone trying to get these patients to do it, well, you haven't achieved your purpose. So you want to, and this is, again, an important lever to think about how your program is going to actually adopt this how your practice is going to adopt this program eventually, because if they're doing too much work, that's not going to work. The third point here is patient engagement, and this one is interesting because when you're starting at a pilot level, you really don't know what your patients are going to do. Are they going to do exactly what you're telling them to do? How much of that are they going to do? How well of that are they going to do? So, if you're asking patients to upload data and you want them to do it every day, is that too much to ask? Or, is once a month too little? And I think the main decision point there is, how does that correlate with clinical outcomes? And what is that critical level of engagement that's going to give you that switch of the clinical outcome that you're looking to achieve? And that's something you can evaluate here. And the fourth point is practice engagement. So, your physician promised he'll look at the data every week, but is he doing it? And if he's not, and if he's doing it once in 6 months, he's probably lost all the patients in his practice and no one's interested anymore. Versus someone who's doing it every day and overwhelming the patients because they want the data every day. So again, this is a critical point that you can evaluate, and always keep in mind that you want to look at it with the lens of outcomes, of some sort of outcomes, be it utilization, be it health outcomes, be it efficiency. And then if you can dig down deeper in your data, depending on your sample size for your pilot, you want to look at how different components affected the success. So, if you're using various kinds of nudges like incentives, you should build in ways in the program design itself so that you're collecting the right amount of data in the right format to be able to evaluate whether that worked or not and how well it worked. So that if it worked really well, give it to all the patients, make it more pronounced. If it didn't work at all, get rid of it and think of something else. The next slide here is, and this is going to go well with what Alex just said. As she said, adoption is something you do at least once. So you go home, you've gone home with your bag, you've set it all up, and you've sent your first piece of data. Done. You've kind of adopted. But then what happens? How many patients actually go and do that? What's the patient uptake? And then how many continue doing it? So, how many patients actually go ahead and do it the second day, the third day, and actually make it a habit? And how many of them do it the first time and think, well, this didn't make any sense to me. I'm not going to ever do it again. And then how do these patients, how do the engaged patients differ from unengaged patients? Because that is really critical to know. How do you move it from that 10% self-quantifiers to the 90% population, which is where it actually makes sense, right? And the other obvious question is, again, how did patient and practice engagement correlate? We found through our research in our programs that, well, if you have really good practice engagement, you have really good patient engagement, and then that patient engagement correlates really well with clinical outcomes. But it may differ from practice to practice. It may differ from a program to program. And again, if practice engagement is really that critical to patient engagement, then you need to think about how you work on that side more, and how do you make it easy for practices to engage, and how do you make it easy for practices to get the patients back. And then how did engaged practices differ from non-engaged practices? And that's a really interesting way of looking at how you can get non-engaged practices to come up and actually take action. And then finally, maintenance. So, let's assume you have critical engagement from both practices and patients. Now, how do you maintain this effect, and how do you maintain the implementation of the program? So a lot of factors go into, thinking about what the satisfaction was, what's going on in the patient's mind. Do they feel more empowered? Do they like the data? Do they think the trends make sense? Do they think it's helping them? Does it empower them more? And does it change their behaviors regarding accessing care? So if all you've achieved these metrics, or if you can evaluate these metrics, it's a really good insight into thinking about what's really happening with the patient. And then what are the incentives, what are the behavioral incentives you can build into the program to really get the patient moving and doing things you want them to do. And then, of course, patient's readiness to change is another tool where you can segment patients into different groups so that you know, here's a group of patients that's going to be really difficult to work with, and you can decide up front whether you want to do it or not, or you want to move with the easiest patient so that you know how it's working, you know the effect, you can prove your outcomes, and then slowly move throughout the curve. The next thing you want to think about is, how did the program fit with your practice culture? I mean, if you had to move a lot of pieces, and if you had to hire new people and get the nurses to not do what they were regularly doing to make this work, guess what? It's not going to work afterwards once your pilot is done. So you need to think about, how did it fit well with the current structure, and how you can modify your program or your pilot to really fit in better with their workflow. And then the third thing, as Khinlei said, ROI, return on investment. So how did the outcomes change, and how did these outcomes justify the cost of implementation? So most of our programs have a positive ROI, and some of them may not have a positive ROI in the first year. But if you know enough about your program, about the patients, and about your costs, you're going to be able to predict over years when you think you'll reach a positive ROI and when it starts making sense to the business. And again, we always need to think about who the R is going to go to, because then that's where your sustainability comes from. And then eventually, this graph, we just want to emphasize that evaluation always leads to some sort of learnings and some sort of refinement. Never think you're going to set up a perfect program. There are a lot of unknowns when you're setting up a program, especially a pilot, and it's really always interesting to know that. It's also interesting to keep in mind that there are definitely going to be changes that you're going to make based on the data, and be open to the fact that your evaluation is going to go back and feed into the various program aspects. And it could also end up just changing your objectives, because you may realize that you were going after something that's unachievable, but at the same time your program has been able to show something that's still interesting, and you want to go and change your objectives and justification, and then based on that, program design. So
Great. Thank you, Kamal. So we're going to move right into question and answer session. We have a few minutes for that, and I think we're going to have someone help us with the mic so we can take it around to people. So questions? Sure. Alyssa, you can see. Right.
Okay. All right. We're sharing this one.
Yep, I think you're on.
So in the program design, are you actually, this is probably for you, Khinlei, are you bringing the target users in there to help think about the needs, not just as a group, but maybe different segments of them, to how to define this design?
Yeah, I think that's a great question. So we try to, as much as possible. We do focus groups all the time. We speak with patients. We speak with the providers. I think what's interesting is that people don't always know what they want. And that's always, there's the art there, and hoping when you're holding a focus group to try to understand what are the actual problems. It's less about it's less about the technology, less about the intervention, but really trying to understand where they're coming from. It's kind of like design thinking, right? It's really understanding where they're coming from, what are their challenges, and how can you're sort of in the back of mind thinking about what you think you want to do, and trying to fit what you're designing with what they're going through.
In healthcare, I think that scalability is very often a big issue. Could you talk about some of the obstacles to scalability in programs that you've seen and ways to overcome those obstacles?
I'll start, and we could go up and down the row here until your neck gets sore like a tennis match. I think the number one thing that I see is so many people try and solve problems quickly by throwing people at them. It's really a healthcare problem, and that never scales. It just does. There just are not enough people, nor can we afford to keep throwing people at a problem. So early on in a program, if an issue comes up and you have the choice between automating it or, we'll just throw somebody at it and we'll have somebody do that manual thing, automate it if you want your program to scale.
I think the other thing that I've seen in a couple of the programs I've been involved with, if you're looking at the provider adoption side of things, one of the ways that we see that providers will adopt quickly is if other providers say this is great. So if you design your pilot in mind with many things, but with provider satisfaction, if you've really understood what really helps them, then an example we have is one clinic was doing this, and providers in 2 other community health centers called us and said, why can't we have this? You know, why do they have it? Why can't we have it? So that is the viral effect, I think, where scalability can work. The issue becomes if you haven't planned for that, then you're in a jam when everybody says, we want it to.
So I just want to add to that. I think from a metric perspective of scalability, what's more interesting is structure of the program and how it fits into the practice rather than outcomes. No one really cares about whether the A1C drop was 1.5 or 1.6, but they really care about it's easy for me to do, I don't really have to do much, it's half an hour of my time and it saves me X. Once you kind of get the structure in place, I think scalability becomes much less of a problem.
Yeah, and more in the ground floor, going to every practice for some of our programs. It really is about the structure, I think. I don't know if this is on anymore. Oh, okay. I'm not good with technology, clearly. Yeah, so it is about that structure. I think scalability is something that you constantly have to incorporate from your learning and do. It's not, oh, we think we've got all these factors, we've analyzed it up the wazoo, and now it's going to be scalable. No, that's part of the constant learning, because even when you think there are elements that you've tweaked to improve, there are still more elements to tweak to improve. And it's just constant refinement and improvement as people start understanding. And this is something new. It's not like you're ripping out one thing and putting in something else that people are familiar with. No one quite knows what that scalability equation actually looks like from the beginning. So you just start to refine your variables and improve them as you go to get that to happen.
While we find the next question, I'll give one quick real-world point about that. We did a program about text messaging, and our #1 outcome measure was whether or not we could do it without pissing the nurses off. And I put that on a poster at the mHealth session in December. And we didn't. They invited us back.
Hi there. Paul Penter from the Jaws and Diabetes Center. I really picked up on your point of the correlation between provider engagement and patient engagement. And I was wondering if you could speak a little bit more on how you can utilize providers as a tool for patient engagement and the interplay, the pitfalls there. Do you want to take that?
Sure. Well, when we started out, we weren't quite sure how important that was. When we started looking at the data, which Kamal can talk about, we started seeing how important that was. So we had kind of a gut feeling that was probably the case, but now we have the evidence to back that up. I think what we need to do now, once we've seen that data, is figure out how to segment those patients so that we're deploying the provider interaction at the right time for the right patients. They're already busy people, so it's about finding the right impact of that engagement tool because they don't necessarily have more time. So getting providers want to do the right thing for their patients. So getting them to do that isn't necessarily that hard. It's making sure that they know that they're doing it in the most effective way that's going to generate the best results in the time that they have. So it is important.
I think one of the interesting facts that came up was when we think about provider engagement, we think about, you need the provider to be really engaged, do a million things. But when we did focus groups with patients who had already used our system, we found that all they really want is mention it when I'm visiting you. A lot of providers would just forget that this patient is on this program, never mention it, and the patient's like, well, he doesn't care. He's not looking at my readings. I'm not going to do it ever again. So it could be as simple as, well, hey, are you using the program? Great, done. Even just that level of engagement makes a pretty big difference, is what we're seeing.
I noticed that we're at time, although we're happy to stay and continue with the questions if you have time to do that. So I'll leave that to the audience. If you have to leave, no problem. But if you'd like to stay and continue, that's fine. And yes, we do. If you are leaving, we do have a handout at the back with some detail of what we did present. Great. Thank you all. Thank you all very much.